Hi, everyone. I'm Liz Seegert, the Health Beat Leader on Aging for AHCJ. This webinar is one in a series of topic-specific training opportunities to brief health journalists on the latest information in a particular health area and to give you story ideas or story resources you can use in your work. Today's topic is Reimagining Menopause, how reporters can reduce the stigma. You know, half the world's population will experience menopause, yet this time in life is often fraught with mystery, misconceptions, and a lack of solid information. Although menopause treatment and knowledge can affect healthy aging, primary care physicians and even many OBGYNs don't get the training or support they need to counsel patients and to help them navigate this phase of life. Menopause patients desperately want to be helped, but come up against a sea of misinformation and knowledge gaps in the media, and even by some clinicians. Joining us today are Dr. Rebecca Levy-Gant, an OBGYN and certified menopause specialist in private practice in Napa, California. She's one of only about 1,300 clinicians with that designation from the Menopause Society. And she's also author of Perimenopause for Dummies. That's a book I wish she'd written about 15 years ago. And Meryl Davids Landau, an award-winning health journalist, editor, and author who writes regularly about menopause for many national publications, including Prevention, National Geographic, Good Housekeeping, and Everyday Health. Our guests will present and then answer your questions. You can ask questions at any time by typing them into the Q&A space, and I'll direct them. We'll go ahead and get started with Dr. Levy-Gant. Okay.
Hi, thank you very much. My name is Dr. Rebecca Levy-Gant, and I am an OBGYN, have been for the past almost 30 years. I live in Northern California now, and I run a small solo private practice. And I always used to think when I started out in OBGYN that the most exciting thing in the world was to deliver a baby. And I did that for many, many years, stopping doing that this past year. But in the past 5 to 7 years or so, I really started to realize that the real pleasure and the real satisfaction comes from helping women go through their menopausal transition and into their menopause years, healthy, happy, and safe. So I started to study menopause more religiously, I would say, and became, as Liz said, a certified menopause practitioner. There are many of us in the United States. We are members of the North American Menopause Society, now called the Menopause Society. And we take certifying exams every year and single year learn new about menopause. So I think those are really important things, trying to learn new things and teach them new things with you. Okay, so basically, for some reason, in the last couple of years, especially maybe the last 1 or 2, menopause has become an extremely hot topic. People are interested in it. Entrepreneurs are opening new companies with the theme of menopause. Women are seeking out treatments. And I think women are starting to realize that they deserve to have accurate information, evidence-based information, and they are able to run their lives safely, happily, and comfortably based on that information. So basically, it is time to stop treating menopause as a disease, because for many years, everyone thought of menopause as a lack of something, like you're missing your hormones, so maybe you should replace them. Your ovaries are not working, so you're feeling sick, you're feeling ill, so we have to make you better. So The Lancet, just this month, as a matter of fact, came out with a lovely series of articles on menopause. And the lead author of that series, Martha Hickey, who's a physician at the Royal Women's Institute in Australia, was quoted as saying, "The misconception of menopause as always being a medical issue, which consistently heralds a decline in physical and mental health, should be challenged across all of society." And I really agree with that. So women in menopause should be treated as a whole. The focus should be on prevention and good health, not just about women who are poor women who are feeling ill and we need to fix them somehow. There's so many things that you can do in your pre-menopausal period, in your transition to menopause, as well as in menopause. It's never too late to prevent disease and also to focus on good health. So generally, we've moved away from the term HRT, hormone replacement therapy, because that term kind of makes us feel like menopause is some kind of an endocrine deficiency syndrome. And now we think of it more as individual symptoms which can be managed. And now we're using the term MHT, menopausal hormone therapy. That includes a variety of treatments and medications designed to take care of symptoms. Just to let everybody know, even though we read things online all the time about hormones being the solution for everything, like women should turn to a particular company or a particular type of hormones to be the answer for their weight gain and hair loss and everything, that's not true, but they're also not something to fear for their dangers and potential side effects. And I speak to women every day in my practice who both feel like they must be on hormones because they heard about something wonderful from their friends or from the internet, and also women who say, I don't want to be on those hormones because don't they cause cancer? I think it's up to us as medical professionals and of course as journalists who are going to report on this to dispel both sides of that myth and make sure that women have evidence-based information so that they can make their decisions along with a healthcare practitioner who knows how to treat menopause. So we talk about an individualized approach that makes the most sense and is most likely to be effective and safe. The way that I look at it is preparation. I ask my patients about symptoms. We prioritize their health needs. I give them evidence-based information, and then we create individualized plans. And that's pretty much how I look at the whole theory and the whole planning for transitioning and into menopause. So I'm going to stop there so that I can allow other people to talk, and I'll certainly be happy to take questions at the end.
Thank you so much, Dr. Levy-Gant. Meryl, what's going on the journalism side?
Thank you. Yes, I thought that was really interesting and a perfect segue into my my part of the presentation here, which is the media. So I'm going to share a few slides and then continue talking after I stop sharing. So these are a lot of women's magazines. This list of magazines has two things in common. One is, unfortunately, they're all defunct. The magazine industry, as we know, is not what it was. But even in its prime, these kinds of women's magazines really didn't want to talk about menopause. So it was something that even in a publication like More, which was for older women, you see their little cover line here, gorgeous over 40. And I think menopause was thought to be too much of a downer and old women, and wasn't kind of the vibe that even women's magazines geared to older women were looking for. And it was very interesting. A couple of years ago, Jill Herzig, who was the editor-in-chief of Redbook, said when she got to Redbook, she noticed that even though their magazine was pitched towards younger readers, a lot of their readers were older readers who had been reading Redbook for so many years and now were older. And she was not allowed to write anything about menopause in Redbook magazine. And she issued sort of a little apology a couple of years ago on the fact of the media's silence in this obviously very important topic. A lot of people think that changed in the media with the New York Times Magazine's cover story, Susan Dominus's experience with hormone therapy. And I think that played a huge role. But I think the change in the media even started happening before that, which is something that I myself noticed. My first piece for National Geographic on menopause actually came out months before Susan's piece. And it was because the science behind menopause is really starting to be fleshed out a little more. So before this new non-hormone therapy came out, I approached National Geographic. Are you interested in doing an article on the science that is behind understanding what goes on in the brain, the neurons that are in the brain that are actually showing to be responsible for hot flashes? And I will say, as someone who has tried to write about menopause for publications, especially outside of the women's sphere, even in recent years, I approached them very trepidatiously, like, would you be interested in menopause? Fully expecting to be turned down. And not only did they agree to run this piece, it did so well, they then assigned me a second piece, kind of looking at overall explanations about what happens during menopause. So I think that people who think, the media, who even experience personally the hostility of the media towards the topic of menopause, that really is changing. These are some of the other pieces I've written in recent years. Good Housekeeping did a huge package of articles on menopause. This was mine. It was just one of probably 6 or 7 pieces. And this is a piece from Everyday Health, which has a whole menopause vertical, looking at the link between menopause and bone health. And then I just looked in more recently to see what articles and coverage there's been that I was not involved in. And Oprah obviously is very big talking about menopause. She did a whole special issue about menopause a little while back. And then these are just some articles from the last couple of weeks. Washington Post had a piece about whether menopause is getting worse. Anybody who's followed the Drew Barrymore, you should use these supplements for menopause online things. USA Today kind of did a piece about that. And this is Liz's piece from Medscape, looking at the link or potential link, or is there a link between menopause and weight gain? So I think there's a lot more interest. Anybody who's interested in writing about menopause should consider the field to be something that you can much more that you can have much more success in now than in the past. So in terms of, what kinds of stories can you cover about menopause, I think the time of doing those menopause explainers has passed. When menopause was rediscovered, as Dr. Levigan says, a few years ago, a lot of publications started doing like, what is menopause and what you should know about hormones. I think now we need to be a little bit more sophisticated and kind of parsing a little bit more, looking at, Black women, Asian women, younger women who transition into menopause, trans men, issues with menopause. Menopause at work is something that I wrote about recently. The way hot flashes and other menopause symptoms are really holding back a lot of women. Some of the lesser covered symptoms of menopause that women complain about, burning tongue and all kinds of other issues, I think is great topics. So, and bioidentical hormones, I think, which, are still very actively pushed online, is something that journalists can certainly look into exploring. I do think I get a lot more press releases now about menopause topics than there used to be out there. A lot of that, I think, is all of the femtech that Dr. Levigan talked about, that with online companies who have, telehealth and also just a lot of apps and things like that. I think journalists obviously need to be really careful about what entities out there are pushing and how much evidence there is for that. And similarly, I think there's a lot of research out there that are very small kind of niche studies. And sometimes I've seen press releases that try to blow that into a bigger trend or phenomenon than the science actually supports. So I think that we need to be careful about that. And then I think even though menopause is having more of a moment than it used to, there's still a lot of doctors who gaslight a lot of women. And I think there are still stories to be told from women's perspectives and not just looking at what the experts think they know about menopause. What the experts know about menopause tends to come primarily from the classic studies on menopause, like the SWAN study and the Penn Ovarian Aging study. And of course, the Women's Health Initiative and Nurses Health Study has some menopause stuff. But I think that, so I think that if you're going to look for evidence about certain things about menopause, you want to look to those kinds of classic studies more than the tiny, small niche studies that sometimes come out. Great resources, as Dr. Levigan mentioned, are members of, and especially also board members of, the Menopause Society, and practitioners who do research in the field as opposed to, or who really understand the field, as opposed to just your local gynecologist who you might call for other types of stories who may not know that much about menopause. And then my final word is to be cautious about stereotypes, even in this day and age. We still see stereotypes about older women, about hot flashes, about menopause being a lack of things, as we talked about. One of the publications that I was working with sent me the PDF of their final article before it went to print. And the art was a, vintage, I guess they thought it was funny, but it was like a vintage 1950s photo of a woman swooning as she's having a hot flash. And I thought that just completely continues this narrative that we are trying so hard to get away from, and that the article that I wrote was getting away from. So when I called it out, they recognized that this was not the best art they could be using, and they did replace it. But I think as journalists, we still really need to be careful. What is the headline? What are the photos? What are the images that are being used for people in the journalists, for editors or art directors who might not be really focusing on, why perpetuating some of these negative stereotypes is a problem. All right, back to you, Liz.
Okay, thank you, Meryl. We're going to open up the Q&A. Please type your questions in the box that says Q&A and not the chat, so I see it. Meanwhile, I'm going to start off with a couple of questions of my own. Let's start with Dr. Levigan. Meryl touched on how a lot of local gynecologists and certainly a lot of primary care providers really don't have a lot of information to offer women. What is it about the lack of training that they're getting that makes this such a tough topic for them?
I think that's exactly it. It is a lack of training. They don't know sometimes what they should look at first. Like, if it's amazing to me how many women in this 40s to 50s time period will come in and say they've already been to somebody, they've been to their primary care doctor, and they'll describe a set of maybe 5 symptoms for me. I can't sleep. I am having mood swings. I'm irritable. I don't have any sex drive, and I'm hot at night. And a lot of primary care doctors, or doctors that are not trained specifically in menopause, put that symptom list together and go, you must be depressed. And the first thing they offer them is an antidepressant. Now, that should not be out of the realm of thinking that this person who has presented with these symptoms might not also be depressed, but there's also a strong possibility that this is a case of hormonal fluctuation or menopause or perimenopause that's responsible for a lot of the symptoms. And I'm not saying people should say, oh, it's just menopause, don't worry about it. I'm saying it's up to them to do more investigating, to talk more deeply, to look into different reasons for different things. And very often we find it's a combination of things: unstable hormone, also some anxiety or depression, plus not sleeping. Of course, people don't feel well. And in the unfortunate 10 to 12 minutes that somebody has to evaluate someone for their problem, they don't have the time or the way of thinking to say, let's do a deep dive into this questionnaire that I have for you and this other, bit of information, and let's get into all these things. And I mean, I have to say, because I'm in my own practice, I do have more time to do that, but people have to have the thought to have the idea to investigate. So if they don't even think about it, how can they help women with those symptoms? So it's not really a well-taught subject. I know you particularly have spoken to medical students about what do they learn, even in residency, about menopause or about how to treat menopause. It's minuscule. It really is. I have to say most of my training came later on in being around those patients and being in the Menopause Society. You have to seek it out.
So, one of the things I see a lot of, and I think many journalists are kind of guilty of this, is that we over medicalize this transitional time. I mean, we don't do the same with puberty. We don't do the same as we're going into young adulthood, but somehow, menopause has become this medical phenomenon, and yet women have been going through this since 100,000 years ago, I assume. I wasn't there, but
Yeah, the one major thing that I hear mostly from women as they're going through this, and we talk about the information and that some of these things are very normal and expected, is that I don't know why nobody ever told me it would feel this way. Like no one sat anyone down and had that talk, like you said, in puberty. Someone must have said, or even at least given you a pamphlet, on this is what's going to happen as you become a young woman. And nobody really says this is what to expect. And that's kind of why I've been more interested in writing about it and getting that information out there so people do know.
I think also, Liz, what you mentioned about the medicalization, I think an important point for journalists is when covering hormone therapy, like the message used to be use menopausal hormone therapy, use the smallest amount for the shortest period of time. And like one expert said to me, that's true of all medication for all patients everywhere. Why would you ever give a patient more than they need for a longer period of a time that they need? But somehow this was like put into a different context, that hormone therapy was somehow so dangerous. You want to make sure you really minimize it. So I think as journalists, we need to be careful if we kind of heard that expression for a long time, not to let that seep into any of our articles going forward.
Patients have heard that message because I can tell you every day someone comes into me and says, oh, well, if I take half of what I was prescribed, isn't that better for me? No, it's not. The prescription strength that you need is the strength to take care of your hot flashes and help you sleep. That's what you need, not if I take less, it's better for me. They have that message from somewhere and it's not from me, so it's out there.
yeah, and I think at least in my experience, a lot of the information out there frames it as an all or nothing approach, so that everybody should take menopausal hormonal therapy or nobody should take it, when it's really it's right for a subset of women, just like any medication is right for a certain subset of people. So what's a good way to kind of frame that issue, so that we kind of get that information out to the readers, the listeners?
I think one of the most important things is for women to understand that the way we prescribe hormones currently and the way it should be prescribed is to take care of symptoms. It's not a panacea for everything that women feel. It shouldn't be in the drinking water like everyone should have it. We've gone through all of these different decades of first thinking everyone should have it. Let's do a study to prove that. That study didn't prove that. So now only the select few should have it, and now it's an individualized approach. What I think questionnaires are key. If your doctor does not say, let me go down this list of symptoms and see what you feel and what you don't feel, because until I bring out the question list, as well as I do, one of the reasons people don't get appropriate treatment for anything is because they don't bring it up. So if you have a set of questions that you can bring out, whether it's talking about libido, whether it's talking about menopausal symptoms, whatever it is, go down the list. And 9 times out of 10, women will say to me, oh, yes, that's just check. That's me. And so, of course, that they're the women who need your help and your treatment. And if I bring the list,
Yeah.
no, not really thing. I only feel this, then it's not.
Okay. I think you froze for a second there, but let me move on to a question for from Meryl while we try to unfreeze Dr. Levy-Gant.
Me?
Yeah. How do we approach doctors? How do we approach medical professionals to help them give the best knowledge to patients in the 15 minutes that they have in that room? I mean, patients come in, and you've seen it, we've all seen it. Oh, you know, so-and-so said this on TikTok and so-and-so said this on Instagram. Meryl, have you ever taken like that information and made an effort to just outright debunk it? And how has that gone over?
You mean with a physician?
Well, yeah, I mean, you know, asking them what the myths are and how, for example, they might debunk it.
I mean, I think for me, you know, I try, if I'm writing about menopause, I really try to go to the people who, as sources, who are knowledgeable, in the hopes that the physicians out there who are not that knowledgeable are reading the same, you know, they're reading the same media. They're reading the New York Times and the Washington Post and National Geographic too. So if they're seeing what the experts are really saying, I think that's important. You know, you were just talking about hormone therapy before, and one of the things that I try to put into most of my articles, which some of the main, you know, researchers from the SWAN study and other, you know, top menopause studies say is, you know, there's nothing wrong with a woman trying hormones because hormones work pretty quickly. And so if a person, you know, is concerned about whether their hormone therapy is right for them, I mean, if they obviously have contraindications, that's a different story. But if they don't, that they can try hormone therapy for a couple of months and see how that works. And in a couple of months, if they're not really feeling better, then hormone therapy is not really going to help them. And if they are feeling better, then they themselves realize why hormone therapy is good for them. And so I feel like by putting information like that in my articles, if doctors out there who are working with women are reading these publications, you know, as in their, not in their medical hat, but just as a consumer, then that might spark somebody to say, oh, let me see if I offer this to some of my patients who are appropriate candidates. That maybe that's a good way for them to accept a trial of therapy. So I think in general, and which is why, again, I think it's really important for journalists to only use people who are knowledgeable about menopause and not just because they have OBGYN after their name, to use those people as sources to make sure that the information that, you know, which helps to make sure that the information that you're providing in the articles is going to be factually accurate, and that is going to help women. So, you know, a lot of my work is about helping women, helping people who don't always get the best information from the medical system. And menopause is definitely one area where that's so true. And I did a piece for Prevention magazine looking at all the ways that women, all the things doctors have told women that are incorrect. And there's a lot of them. Because if menopause is so misunderstood by society, it's going to be misunderstood by physicians too. They're not immune from that.
Yeah,
So.
and I can say that probably between 4 and 8 times in a day, I use the word evidence-based. You know, that when someone asks me a question, I want them to know it's not my opinion that I think they should take something or not take something. I always say what the evidence shows, or what the latest evidence shows, that this is what's safe and effective. Because if someone comes in and says, don't hormones cause cancer? You have to really unpack that. Like, where did you hear that from? The internet. I know of an old study. A lot of people are familiar with the WHI, and they feel like the only thing that they came away with from the WHI is because probably of a headline in a major newspaper that said hormones cause cancer. So everyone went off it. And it's amazing how a study from so long ago still holds this cloud over anything that I can tell my patients, because they heard, or that it was a study. And I tell them, you want to know exactly what that study said? I'll tell you. And that's a 15-minute conversation to try to say, the good things we found out from that study are blah, blah, blah. The things that we found out that we shouldn't do anymore are this. And they're pretty impressed by the idea that we can, you know, kind of take that study and break it down to say, this is really what it said. It's not one point of information that you can take away and go, that's the way I'm going to live my life because I think this. And
And
also,
go
I'm
ahead.
sorry, for me, it's okay if someone decides they don't want to be on hormone therapy, but I want them to walk away with the right information to make their decision.
And in terms of what you were saying about everybody still kind of clinging to the conclusions from that headline, which were not the conclusions of the study, and certainly as the study has been parsed and reevaluated over the years, does not show that most women are at risk of cancer from taking hormone therapy. That study actually looked at older women who started hormone therapy well past menopause for the most part.
Right.
So it wasn't even the way we use hormone therapy today for women who are going through the transition or just after. So I think it's very interesting. But I did speak to a physician, right, who told me this was right around the time that the New York Times Magazine cover story on hormones came out, and she told me that the day before that study, that article came out, she had been talking to a patient about hormone therapy who she felt was the perfect candidate for hormone therapy, and the person was very resistant, citing the Women's Health Initiative study and other things that they'd seen and heard online. And she told me the day after that study came out, the woman called her back and said, okay, I've reconsidered. If hormone therapy is right for me, then I probably should try it. So really that's the power of journalism to help to correct some of these pervasive menopausal myths that are out there, I think is important.
So we have a couple of questions from our audience. So one journalist wants to know, isn't part of the issue with practitioners and education the focus on HRT versus other potentially beneficial strategies that are only backed by observational data? How do you overcome this, especially from the standpoint of more serious outlets? So in other words, we're talking evidence-based, but a lot of these studies are observational as opposed to random clinical trials.
Well, I think you have to make that distinction for patients what patients understand most when you're trying to talk about studies, because in all honesty, the big problem, and I don't want to get into this, is that no one really knows how to evaluate data. So like if I tell somebody this is what the evidence shows, if I don't really explain what that means, that they think that that is just as good as an article they read online that comes from the company that manufactured whatever it is they want to take. They look at those things as equal because they don't know. So I think you have to tell people what it means when there's an evidence-based study. And I'm just going to use an example. There's a treatment that we used to use for some types of abnormal pap smears, and we don't do it anymore. So we don't do it because they found that women who underwent the treatment and women who didn't undergo the treatment 20 years later, they both had the same outcomes, the same amount of cancer, let's say, in both groups. So I explain that to patients by telling them, so what does that mean? So in the end, doing it was the same as doing nothing. Do you understand what that means? That means that giving this particular medication, doing this treatment in an evidence-based random placebo-controlled study can tell you whether doing that is the same as doing nothing. That's an understandable way to evaluate literature, So I do think when you're talking about evidence-based literature and you have the data behind it and you have the numbers behind it, you do have to tell them that observation is kind of like an anecdote. If I have 10 people that come into my office and tell me, I love this medication, it's great, do then I have an obligation to tell people this is great, take it? No, that's not how I make my decisions. I can tell them 10 people thought it was great. And you know what? That holds the most weight for some people. When people come in and they want to do something, the number one reason they want to do it is because someone they know did it. And that's not evidence. And you have to tell them that. And you have to put the caveat in there that just because your friend got this result doesn't mean you're the same person and you're going to get that result. So those are kinds of things you have to explain to people. So I think it's the obligation of the practitioner to explain the way studies work and why we recommend what we do.
And research has also been done on a lot of the supplements that people have used for menopause. And I mean, as a person who writes about a lot of mind-body work and holistic health, no one wanted some of these supplements to be more effective than I did. And the research just has not borne that out. I mean, there is no good evidence that any of the supplements that are recommended online or by your friend for menopause works. There's no good evidence of that. And some of them have been studied pretty extensively. Some of them haven't, but there's been some, pretty rigorous research on some of them. So
The
again, when
Menopause,
you're,
the
yeah, when
Menopause
you're,
Society recently put out a very good paper about here are all the things that are pretty much known to be marketed as helpful for menopause that are not hormones. And it's very long, but every single category, and some of the ways they phrased it was like, this is not recommended. That doesn't mean they know it's harmful. They just don't know
right.
that it helps you. So the way a lot of people practice is that if someone presents me with, I'm taking this, what do you think of it? I will look it up. And of course, the first 3 things that come up are from the company that produces it. So you have to discount all of that conflict of interest. And then, you have to say to people, I don't have evidence that this is helping you. But if it's something that's likely not harming you and you want to use it and you feel better with it, I can't tell you not to use it, but I can't tell you I recommend it either. And that has to be our bottom line for people. You can't have the conflict of interest of, maybe I sell this in my office and maybe you want to buy it because it's a better something. You can't do that. Those would be red flags.
So we were talking about MHT before. Another question here: how advantageous for patients is it to treat an array of menopause symptoms individually, like hot flashes or joint pain, piecemeal versus a more comprehensive MHT kind of approach? How do you kind of rationalize, if I'm coming into you with joint pain or I'm not sleeping, would you be giving me, multiple medications, and then we have a concern about over medicating the patient?
Right. Probably the major thing is to go back to that questionnaire I was talking about. If someone has hot flashes during the day that are interfering with their day and night sweats that are waking them up at night, interfering with sleep, then the top of the peak of what to treat with would start to talk about hormones, mainly being estrogen. Once you decide that estrogen should be part of your plan, then of course you have to look down the list of, how can I safely give this person estrogen? 1, are they in the window for treatment? Are they within 7 to 10 years of their transition? Are they a candidate for estrogen? You have a whole bunch of questions you have to ask about that. 3, how should they get their estrogen? Best way, of course, due to some of the studies, is it should go through the skin. Do they have their uterus? If they're taking estrogen, then they need to take progesterone. So again, a questionnaire of sorts, that if estrogen is going to be part of the plan and you give it to them safely with or without progesterone, depending on their situation, I wouldn't add in a lot of other things then to say, and this is for your joint pain, and this is for your depression, and I would do the estrogen and progesterone if that's the program first, then you reevaluate, because that may or may not take care of their vaginal dryness, that may or may not take care of their libido, that may or may not take care of their poor sleep that may not be related to flashing. If someone is now not having night sweats, but they're waking up for some other reason, you don't just keep increasing their estrogen dose because they're not waking up from sweating. So again, individual symptoms that you treat with the one thing that is most likely to take care of the hot flashes and the night sweats, because those are usually the worst in general. And then you stack. I always talk to my patients about, we do this first, and then we add other things in, which may be, you still have vaginal dryness, now you need a vaginal estrogen as well, or other vaginal preparation. You're still having anxiety and depression. Now let's evaluate whether we need to add in something else. So not to over medicate, but to address everything, yes, with the fewest things, but not to leave anything untreated, because a person who's not hot flashing but still depressed is still a depressed person.
Gotcha. Question for you, Meryl, I think. Should we explain what an evidence-based placebo-controlled study is in every story when we reference that type of study? And how do we make space for that in stories with limited word counts? I thought people knew what was meant by double-blind study and so on.
I never use the term double blind or even placebo controlled, even in a publication like National Geographic, which has a more highly educated audience. But I do generally reference the size of the study. I reference whether one group was taking the medicine and compared against a group that wasn't taking the medicine, as a way of differentiating that between an observational study. But I think it it's important not to get into the kind of jargon that if you were, at a cocktail party and you said that to someone else, they would have no idea, because then they might skip over the whole paragraph. I don't even understand what that means. And then they're missing the important information that you're trying to convey in that paragraph. So I think, evidence-based, placebo controlled, for those of us who write health journalism, that's 101. But out there in the real world, I try never to use terms like that.
I do
Yeah,
think it's
I would,
important to let patients know that they should not be looking at studies that are done by the company that's selling a product. Not that it can't be a good study, it could, but you can't tell.
yeah,
You can't tell.
especially if the results are transmitted by press release.
That's true.
So yeah, and just a reminder for those of you attending the Health Journalism Conference in June, there will be a session on how to evaluate medical studies. And if you're shaky on it or not sure, it's definitely a good session to sit in on. Question for Dr. Levy-Gant. There's a focus on treating menopausal symptoms, but what about other aspects of health changes at menopause? Are most doctors well equipped to advise women about how the risks of cancer, heart disease, osteoporosis, et cetera, change and what to do about it?
I do think most primary care doctors have that knowledge. I mean, we are very blessed as women's healthcare providers to be able to not just take care of some gynecologic problems, but also to look at the whole person more or less. So I think any doctor that's equipped in looking at the whole person, which should be the trend now, I think, is equipped to do that. And of course, now the two big things in medicine right at this moment, as I see it, are menopause and weight loss medications and programs and things like that. Because I mean, that's a whole other area of, incorrect information and people using the wrong drugs for the wrong reasons and stuff like that. So I think it's definitely worth those conversations to talk about future risks of cancer and osteoporosis as related to the whole person, the weight, the blood pressure issues, diabetes, all of that. It all factors in there. Who has that much time to address all those problems? But I'm only here supposed to be addressing the gynecologic parts of the problems, and I do end up addressing. This morning I started someone on a blood pressure medication because she's my patient for a long time, and I can treat that. So yes, I do think primary care doctors are equipped, and if they feel ill-equipped to handle the menopausal part of it, send them to someone like me who will do that. But don't treat them improperly and then have them come to me because they're on the wrong thing or that they feel like somebody didn't listen to them. I mean, one of the best things you can do in medicine is refer. You should have a little network of people that you really trust to say, I don't have the time or the knowledge or the interest to handle this person's menopausal problems. Go to this person. And that's perfectly adequate. That's much better than a patient coming in feeling like they were not listened to.
Agree. We only have a couple more minutes, so I want to throw out a final question actually for both of you, which is what should journalists be writing more about? And what are we getting not wrong, but not as right as we could? That's for Dr. Levy-Gant. And Meryl, we'll flip it for you. What would you like to be writing more about? And where are the gaps? So Dr. Levy-Gant, let's start with you. What would you like to see more of us health journalists be focusing on when it comes to menopause?
Wow. Well, the type of articles I would like to see for women, I think should not focus too much on here's how you can lose that weight that you've gained in menopause. And here, I feel like they should be kind of more uplifting maybe about, here are the types of exercises that would be great for you to do to stave off osteoporosis. And it's never too late to do that. I mean, I'm always looking for articles like that are understandable for my patients that I can make a copy of and give it to them when they walk out of the office, rather than some, medicalized kind of article that's talking about their T-scores and their bone density tests and stuff like that. So things that would be informational correctly, that would be easy to follow for patients, that they could add them easily into their lifestyle. And less of like, go use this magical, combination of things to feel much better, and to teach people to be skeptical of what they're reading. Because if I had one wish, it would be that I don't have to spend the first 10 to 15 minutes of every visit dispelling what people come in with and then building up the information. I would love them to come in with kind of a blank slate, like, tell me about my menopause. Wonderful. Not like, well, I know someone put you on that, but I'm kind of against that. That doesn't go, I don't really even say it's my opinion that I'm against it, because it's a sensitive issue, but I always say that doesn't go with the guidelines of the Menopause Society, and that's where I get my information from. So I think I would love to do less of that.
Meryl, what about you? What do you want to be writing more about?
I mean, I think there's still a lot of menopause stories of things that are, so I think now we've reached the point where we're talking about hormone therapy. We're talking about women who are really disabled by the kind of menopausal symptoms that people had to kind of hide and not talk about before. But I still think there's so much about women's menopause experience, and that means the perimenopausal period, actual menopause, and then even a couple of years after. I think there's so much that people are still not talking about, that people still don't understand can be linked to menopause, that there's the symptoms that are attributed to menopause, again, come from these studies following a relatively small number of women, given the universe of women out in the world. And then we've determined that these are the most prevalent symptoms, and no doubt they're the most prevalent. But if you're a woman who all of a sudden feels like you're having lightning bolts in your brain, and that shows up in some of the menopause studies in this very small number of women, but those women, like, they want to know, this is real, this is linked to menopause, why is this happening, what to do about it. So I'd like to empower more women to share their stories about what they're experiencing and how this is still affecting them in life and at work and things, even if they don't have necessarily the classic symptoms or the biggest problems. And I'd like to see more treatment. I know that, Veoza, we talked about before, the non-hormonal treatment that works on the candy neurons in the brain. I know more treatments are out there being studied. So I, obviously would like to continue to follow the treatments, and hopefully there'll be more things that can be offered to women in the future.
Well, unfortunately, we're out of time, although we could probably go another, hour talking about this.
I can talk all day.
Well, that is your day job, kind of. So I want to thank Dr. Rebecca Levy-Gann and Meryl Davis Landau for joining us today. Thanks to all of you who tuned in. If you joined us late, you'll find the recording of this webinar at healthjournalism.org in just a few hours. And once again, thanks to our presenters for taking time to share their expertise. AHCJ will continue to bring you webinars on a variety of health topics as a perk of your membership. Thank you for joining us today, and good luck on your stories.
Thanks, Liz.